You're listening to The Q Switch with your host, Spence.
Welcome one and all to the Q Switch Conversations podcast. I'm your host, Spence, and the mission of this show is to tackle subjects currently impacting ophthalmology and pull in leading eye care professionals and industry players to discuss their unique perspectives. So let's jump right on in. In this episode of the Q Switch, we are joined by Anjali Hawkins, who is a glaucoma specialist at Geneva Eye Clinic and also an assistant professor at Rush University in Chicago. So doctor, where are you calling from today?
I am in New York City currently. I'm here for my daughter's graduation, so speaking from the hotel room.
Well, thanks a lot for making time. Really do appreciate it. And congratulations to you and your family on your daughter's graduation from NYU.
Thank you.
So in this episode, we'll be discussing the continuity of care amidst equipment failures in ophthalmology. This has been a very hot topic since we launched the show. So what's been your experience with this and how's it relevant to your work?
Well, I mean, just like owning a home, there's always something that goes wrong, some piece of equipment that's not working or has to be kept up. And, our schedules are so tight that if something isn't quite right, it just throws everything off. And one has to learn to kind of stay calm and troubleshoot and figure out, one thing at a time.
Well, cool. Indeed. So again, great to meet you, doctor. And it's a pleasure having you on the Q Switch. So Geneva Eye Clinic has a rich history, as I've learned. Can you tell me a little bit about that? And in addition, include something unique about your personal career journey into ophthalmology?
Sure. Well, let's start with my personal career journey into ophthalmology. My father is an engineer, and we joke around, from a immigrant family, we were given a choice. My dad said, you could do anything you want in college. You can be an engineer or a doctor, and at that point I was like, okay, I chose engineering and I liked it very much. But one summer visited my uncle, who's was an ophthalmologist in New Orleans. And he showed me his office and pictures and telling me that you can diagnose diabetes and hypertension by just looking at someone's eye, and found that quite fascinating and kind of did a quick turn, finished up engineering, but ended up in medical school right afterwards. And with the whole time, my goal being ophthalmology, was fascinated by it. In medical school, even today, there's very little curriculum in ophthalmology. I was lucky to have a 2-week rotation because I sought it out because that's something I was interested in. And so, it's just luck and fluke that I chose ophthalmology and got into it, and I absolutely love it. In terms of Geneva Eye Clinic, I was very fortunate. That was my first and only job after fellowship and residency. It's a suburb about 45 miles west of Chicago, so my residency was at Rush and in Chicago. This is a great little group I found. It was two groups of 2 people that merged, and so it became a 4-person group in 1996, and then they called themselves Geneva Eye Clinic. I joined as an associate in 2001. I love the group nature of it. There's 4 people and everybody has a different subspecialty. Everybody does comprehensive. It's a small community, Geneva, Illinois, about 30,000 people. So it's a great place to live, great place to practice. And I love having partners versus solo practice, where maybe you make all the decisions or you carry all the financial burdens and so on. This is a shared thing. It's great to share patients and to learn from each other. So I've been very fortunate. I don't think very many ophthalmologists or physicians can say that you're still in the same group you started with. I'm now the managing physician, and just love being there. And 1 day a week, I drive to the city of Chicago and teach at Rush University. So it's just a great schedule to be in private practice, help run a business there, and then go teach 1 day a week at the university.
Well, thanks for sharing that story. I think that they're very fortunate to have you. Oftentimes we spend more time at work than we do at home. And so you want those times to be, filled with positivity and things you really truly enjoy. And I can just hear from your voice and how you're talking about it that's how you feel about your work. And then also with the Rush thing, you mentioned that was a program you had come from, and to be able to visit and still have ties with that program, I think are also truly unique and special.
Right. Yeah. I love working with the residents, medical students, and it does feel like home since I trained there.
Yeah. Well, my kind of association with residents, I was with Alcon Surgical, which I'm sure you're familiar with. They're kind of the big dog on the porch in ophthalmology for equipment and whatnot. not. I spent about almost 14 years with them, and I spent the majority of that time as a surgical academic manager. So my role was to pretty much host all and help manage and work with the teams that supported all the academic institutions in the Southeast. I live in
I
Miami,
see.
so Baskin Palmer's like my home, but also like Emory in Atlanta, both of the UF programs in Florida, UAB in Birmingham. So yeah, it was something I really enjoyed. And even now, with my role with Meridian, I try and when we interact with some of the academic institutions, I offer the opportunity to work with our lasers as a part of their resident wet labs. So, and I can offer the
Yeah.
same to you as well. At
I mean,
Rush.
Alcon's really wise with that because they get to know the residents at a very early time in our careers. And
Yeah.
then we use all their equipment and we graduate and we go to our community hospitals and say, hey, I want the Alcon machine.
Well, I will tell you this: when I first started, I started with Alcon on the pharma side, and then about two and a
Uh,
half years in, had the opportunity to move to the surgical side, and it was a unique position. It was kind of the unsung heroes of Alcon. There's like the team of 14 of us, and we were the only players in that space. Fast forward 7.5, almost 8 years, and every single manufacturer of ophthalmic products, B&L, J&J, they all have an academic person now. So it's not as
yeah.
we weren't flying under the radar. But when I transitioned from Alcon to some other opportunities, we were not the only player in that space. Everyone had a program. Everyone was offering up wet labs. It was no longer a secret. Let's just put it like that.
Right. Yeah.
So let's go and move forward here. Let's start with a bit of context. Can you share a moment or situation where critical equipment failure disrupted your glaucoma clinic, and how did it affect your ability to provide care that day?
Well, glaucoma clinic, couple of the things that we routinely do is a Humphrey visual field and a OCT. And there's been times where the visual field is not working. We can't get it to run. We've done it or it hasn't saved, things like that. So sometimes if it's something minor, for example, it won't come over to my EMR, it hasn't printed out, then I have to walk up and look at it as a technician brings it up in a different room. But sometimes it just doesn't work at all. And there's some error codes. You try to call the company, but sometimes it'll be till next Tuesday that they can come look at it. So it is very disruptive. Humphrey Visual Field is a key piece of test results I need to make a decision on whether somebody's current medical regime is enough or whether they need surgery or laser. Glaucoma, it's not life or death. It's a slow moving disease. So you just very frustrating and the patient's frustrated. Although I have to tell you, they hate taking the Humphrey Visual Field. So they are almost happy that it's broken. You just have to remind yourself that, okay, the day's not exactly the way I wanted it, but we're going to have them come back. Let's just do a pressure check or look at their optic nerve and they're going to have to reschedule. So that's a good thing about ophthalmology. It's not a cardiac ablation you're delaying to next week.
Well, that's such a vivid example, one that I think many clinicians can relate to. Let's talk about why that kind of disruption is especially critical in glaucoma care. In glaucoma, timely and accurate diagnostics are essential. What's at risk clinically and legally when devices like OCTs, visual field machines, or lasers go offline?
Well, again, I think, as I say, glaucoma is a slow-moving disease. So if you put off a visual field for a week or even a month, I don't think for most, great majority of patients, it's not going to make a big difference. And if the intraocular pressure is so high that some decision has to be made on surgery, then I don't think we're waiting on a Humphrey visual field or an OCT result. We just have to say, pressure's 40, pressure's 50, or patient's very uncomfortable. Then we just make a surgical decision without those pieces of equipment. But the visual field and the OCT, these are for patients we're following every 3 or 4 months and monitoring to see if their pressure needs to be lower. So it's not critical and it can get put off by a couple weeks, couple months if needed.
How common are these failures in your experience, and are most clinics adequately equipped, or do you find that backup plans are more reactive than proactive?
Yeah, I mean, I think failure of a visual field or OCT for us has not been very common. It feels super disruptive, but things that are more common, for example, is the EMR not working, the EMR being slow. Back in the day when we had paper charts, every now and then you couldn't find a chart or you couldn't find a note. And that was so much easier than now when you can't even log in. Like, you ask the patient, why are they here? And they're just like, oh, follow up. You don't know anything about them. You don't know what medicines they're on. And, all these cloud-based EMRs that can cause a big problem, or there's a software update. That's the real issue more so than the machines. And so, can't be on Wi-Fi. We moved over to fiber. If there's a problem, it's going to be solved much quicker. It's much faster. But that's the biggest fear is logging on every morning. Can you actually log into the patient's chart? Because there are days you can't, or it's just so slow, and you're trying to get a hold of the EMR as to what's happening. That's completely disruptive. And I mean, because, if you're spending 10 minutes per patient instead of the 5 minutes you had allotted, but you're just waiting for that circle to load the chart. There's nothing you can do, nothing more frustrating. So that's very important to keep up with the EMR, the updates on it, all the software.
Mhm.
And every time there's, tonight there'll be a software update. You come in the next morning holding your breath, hoping that it's still exactly the way you remembered it the day before. It can be very disruptive.
From an operational response standpoint, when something goes down, what does your immediate workflow response look like, and how do you triage patients, adjust schedules, or communicate with staff and patients?
Yeah. So the first thing is just, if we can get a hold of the company or the EMR, whatever the problem happens to be, then we try to get an idea of how long this is going to last. I mean, for example, if there's a storm and there's a power outage, which we've had, then none of the slit lamps are working. So you're calling the city to saying, okay, what's the predicted? Is it 1 hour? Is it 2 hours? You may have to cancel that morning and then keep the afternoon patients. And we've had tornado warnings, get every single patient in the basement and wait for all the power to come up and get all the patients back. So it's just, you just have to go situation by situation. But there's 4 of us partners at the clinic. And depending on who's there, someone along with the business manager will begin to manage things, what patients are going home, what patients are getting rescheduled. Yeah, it's just a day by day. Sometimes the phone lines aren't working.
Well, it sounds like quite the high wire act behind the scenes. But beyond logistics, I imagine there's also the patient-facing challenge. How do you manage patient expectations when delays or rescheduling happens due to the technical issues, especially in glaucoma care where follow-up and consistency is so critical?
Yeah, I mean, I think I'm pretty lucky to practice where I do. Most patients are very understanding. If you just make some comment about, oh gosh, computers, I don't know. I don't know anything about them, and they totally just seem to understand if you just blame machinery or technology. But there are some patients that have taken the day off work or to bring their mom in, or can be more impatient. Just have to deal with that on a case by case situation. But in general, you just try to explain it's beyond your control, and that they're not typically being asked to be inconvenienced or be delayed all the time. So if they know that about me as a physician or Geneva Eye Clinic as a doctor, I think they can be more understanding that sometimes a piece of equipment isn't working, or I can't get the slit lamp turned on, or maybe 2 technicians called in sick. These are just all real things that happen every single day. And hopefully this is not happening to that patient again when they've come back 4 months later. So most of the time, they've had a good experience, so that every now and then when something isn't working or we're running behind or power cord is out, then they're understanding.
Well, I'm also a patient whenever I go to the doctor, whatever it is. And sometimes wait times are long, things go down. I've experienced that as a patient in different settings. And I've been very, very fortunate to have great places I go to for medical care. And when something does go wrong, they are highly respectful, very apologetic, and just really transparent. And those are the ones where, so, you know what, not a problem. I can come back, or, I can come back in an hour, or I can wait so long. But that ability to communicate what's going on in a respectful, meaningful way that makes them feel like, you know what, I care about you. I'm sorry the situation. We're going to deal with it together. Those tend to have the most successful patient interactions and most compliance, if you will, cooperation from the patient side of things. And it sounds like that's similar is what happens at Geneva Eye Clinic.
Right. And we're still striving for that every single day, because sometimes you just, you fall behind, and then you're rushing because you're falling behind. But what needs to happen is that we communicate with the technicians communicate to the front desk, and then the front desk communicates with the patient saying, just like you said, we're very sorry, respect your time, we're just running behind. And sometimes it's due to equipment failure, sometimes it's just complicated patients that have come in, or someone that's had an emergency that we fit in that we would do for somebody else. But I find that if you communicate with the patients, they're much less likely to be angry about it. But if you just keep going about your business, which tends to be our first reaction. We're behind. Let's just keep going. Let's just keep going. Don't slow down. But actually, if you slow down and communicate with all the parties involved, so that they can talk to the patients, it's much, much better. But we're still working on it. We're not perfect. We're still striving to get that done every day.
Yeah, I don't think there's a finish line in that particular race. You just got to keep on, one foot in front of the other, as they say.
Right.
So let's talk about continuity. What are the downstream effects on disease monitoring or treatment outcomes when there are delays in imaging or pressure checks?
Okay. Well, glaucoma is a progressive disease, but for the most part, it's a slowly progressive disease. In general, glaucoma patients, we can categorize as mild, moderate, severe, and they're followed every 3 to 4 months, sometimes 6 months, with some testing, either a pressure check or look at the optic nerve, a visual field. And in general, we ask patients to make that appointment on the way out. So there should not be a delay in care unless they have gone home and forgotten to make that appointment. And we have checks and balances for that, or people that have called in sick or, can't make the appointment, but then we have checks and balances for that. So for the most part, it works very smoothly because when they leave, there's an appointment available for them 4 months later. Now it's the patients that fall through the cracks or didn't call back. And this happens time and time again. 2 years later, 3 years later, they come back. And now there's a drastic change in their visual field or something's happened. It's pretty interesting how some of them still keep getting their intraocular drops for glaucoma or their topical medications for glaucoma, either through their medical doctor or they've been to a different facility. It's, I don't know, because for our clinic, if you haven't been in the last 6 months, we won't give you refills.
Mm-hmm.
Somehow patients squeak by or get them, and then that's the real problem. Then they show up, and that was missed both by the patient and it's a little bit on the doctor too, as far as why didn't we get them back? Did we assume they were somewhere else? And now there's a drastic change, and sometimes that results in visual loss that cannot be brought back.
Right.
And something more drastic would have to be done. Instead of resuming their medications, we may recommend a glaucoma procedure, a surgery, to make sure that this doesn't happen again and that we bring down the intraocular pressure to a low level.
So let's pivot to solutions. Given that failures are inevitable, as you mentioned before, what safety nets should we be building in?
Yeah. The safety net of trying to get the patients, not to lose the patients, that happens for various reasons. Part of it's compliance and cost. So if a patient does not come back in 4 months, why did they not come back? Do they, are they afraid of the disease? Do they not know enough about it? Maybe they can't afford the copay or the medications. How do we address those situations? And that's very complicated. For glaucoma patients and for pediatric patients, for example, we keep special lists to make sure we're not missing someone, that everybody has come back. I tell glaucoma patients to just, even if they can't afford it, to keep in touch so I can figure out if we need to see them when they've lost their insurance. We can see them without having insurance. We can try to give them samples, whatever we can, because if this is a disease, once vision is lost, we can't bring it back. So the best thing is to maintain it and to keep it under control now before something drastic happens. And education's a big part of it. We have a lot of our patients that understand that and a lot of our patients that don't, because this disease does not cause pain, does not cause your eyes to be red, does not cause any problems. In fact, the medications may cause pain and eyes to be red, but when they're not on treatment, they don't realize anything's wrong. So, and that's the real issue with glaucoma, is to try to explain to patients that we need to get this under control now, even though you have no symptoms and no loss of vision.
So you mentioned a couple of times trying to get patients back and the patient communication. I think that's unique to glaucoma because the patients have to always come back so you can manage their condition.
Right.
In terms of like AI and some of these other technologies we have that we didn't say 10, 15 years ago, is that ability to communicate and keep patients kind of on that cadence of coming in every 2, 3, 4 months, is it easier with some of this technology? And do you use it, or do you feel just as challenging as before? What's it look like for you in terms of managing those patients just from a compliance and showing up when they're supposed to help you manage their situation?
Yeah, so we do have tools for that now that we didn't before. Before you just made a list writing it down.
Right.
The front desk manager would write a name down. But now we know, if you were supposed to come back in 4 months, or a year, we have all these, protocols. We can flag those people and say, hey, you missed your appointment. If you called and canceled, the the software will pick up that they were supposed to be here and they haven't been here. So we can definitely be more proactive about calling and letting people know that you've missed the appointment. So communication can happen. We have some patients that then still won't call us back. And at some point, you also have to make a decision if you think their disease is a blinding disease and they're not being compliant, even though we've tried, then sometimes you have to send a letter dismissing them saying, no, you're not following our advice. So these are other doctors you may need to see. But in general, we try very hard. And the tools, I don't know if it's AI exactly, but the software tools that are built into EMR or that we pay extra so that we can keep tabs of these patients have been very helpful.
I would imagine that the challenge is that, I think it's just natural human condition, human nature, that you don't react until there's pain. And because glaucoma has no pain associated with it, it's like, you know what? They don't take it as seriously as they should. And so
Right.
I think that is a barrier to that compliance and that cooperative patient coming in, because they don't see it as being serious, quote unquote, because they're not feeling
Right.
any pain or discomfort and no adverse effects, but yet they have this condition that can blind them. So I'm
Right.
sure that's a challenge that you and every other glaucoma specialist have to face, trying to really battle that patient. Like, look, this is serious. Even though you don't feel anything and you seem fine, you're not. You have this condition
Right.
that can blind you.
Especially now, a lot of our patients get selective laser trabeculoplasty as first-line treatment. So you tell them you have glaucoma, you need this laser, this is really going to help you. And indeed, it does help them. But now they notice you're asking them to come back every 4 months and you're not making any changes. The pressure is the same, the visual field is the same. And then they begin to go, maybe I'll make that every 6 months. Maybe I'll, and I do worry about those patients sort of falling off and us not following up with them as regularly versus patients that you have on your latanoprost or your topical eye drops. Well, they still need their refills. And my office will say, no refills, you haven't seen the doctor. So then they are more likely to come in because they need their refills. So I think laser becoming so effective and first-line therapy is making a problem for us to keep up with the patients or making sure the patients keep coming back every 4 months as we want, because we don't know if the laser stopped working or if the pressure's gone up or what else has happened, because just like you said, patient doesn't feel anything at all. They feel great.
You mentioned SLT as a first line treatment. How long have you been doing that? Because that's just kind of become the new thing. Not shouldn't say new, but it's transitioned over the last decade since the light study. Were you an early adopter to first line treatment with lasers, or was it more recent transition for you?
I was an early adapter. When we first got the SLT, I offered patients that were on one drop or even 2 drops. If you want to do the laser, then we can try to get you off one of your drops. So I did that very early on. Lots of patients took me up on it. And then I have been offering SLT as first-line treatment to every patient. I would say about 80% of patients up till recently still chose medication and didn't want the laser. But I think I've sort of changed my approach on how I discuss this with patients, given the recent study. And now I'm more likely to say, the laser is a first-line treatment. We should definitely try that first. It's safe, it doesn't hurt, takes a few minutes, very successful. If it doesn't work, we can always use medications. If you go to a meeting and you ask ophthalmologist, if you had glaucoma, how many of you would want SLT? Everybody raises their hand. And then when you ask them, how many of your patients take SLT as first treatment, only like 10% raise their hand.
Wow.
So it has to do with how you present it to the patient. So I think more and more it's first-line therapy for all ophthalmologists, although I think glaucoma specialists have been using it as first-line therapy for a long time.
Yeah, it's gotten to the point, at least in my travels, particularly with Meridian, because we sell lasers, is that it's not just the glaucoma specialists. I've got refractive guys who are like LASIK and cataract, like wanting to invest in an SLT laser. We're getting calls from guys who I wouldn't normally expect to, purchase a laser because of the reasons you just said. That there's a lot of patients out there. Number one, there's more demand than there are specialists or ophthalmologists to serve them. But it's the kind of thing that you can get folks off drops. All the things you mentioned with the light study is highly effective. So it's not just you guys anymore. It's other folks that you and other subspecialties within ophthalmology that are taking on that same SLT as a first line treatment for those patients, especially those early onset. That was kind of a tangent because you had started that conversation. So thanks for that. So getting back on track, what kinds of redundancies, whether equipment, partnerships, or data, should practices have in place, and how feasible are these for small or mid-sized clinics like Geneva Eye?
Yeah, I mean, it's very difficult to have redundancies because that costs a lot of money, and the margins are so low with insurances cutting reimbursement and us having to work faster and faster. We don't have a lot of redundancies. Just for example, if the OCT goes down and maybe the Optos can help you with something retina wise, but you can't do both of those the same day. So if one goes down, you can do the other in terms of reimbursement. But even though it makes sense to have a backup machine, for example, there's just not enough. Yeah, we don't have enough money to have 2 OCT machines or 2 Humphrey Visual Field. We don't have the volume as a small practice. If you're a large practice or a university, maybe they have the volume. And it's also room. All of those pieces of equipment take up real estate. So that's a room that could have been with a slit lamp, could have been a workup room for a technician. You can't just have a machine sitting there all day that you may need just in case.
Yeah, you got to right size your practice with equipment that's going to fit and obviously accommodate the space, because there's clinic flow. And again, I've worked with lots of practices that say, I mean, what's the footprint of your laser? Because look, we have a room that's filled with our diagnostics and it's got to fit. And if it's too big, we have to go with something different. It's totally makes sense.
And the two lasers in the same room, argon and the light delivery device. Well, if one doctor is using the argon, then the other laser or light delivery device cannot be used. So it's complicated.
Yeah. You mentioned a couple of times that, when something goes down, you try and call the, service provider, the manufacturer. So in your view, how much responsibility should fall on the manufacturers or the vendors? And are current service agreements and turnaround times realistic for today's clinical demands?
No, I mean, it's very difficult. We were talking about the SLT. If that goes down, it's a minimum of $2,000, and they send a person from California. So they're not coming tomorrow. They're coming the next week or 2 weeks. So that laser is down for quite some time. Some of the other things are more local, but, just like your washing machine at home and so on, sometimes there's error messages and they can help you navigate that, at work. So one of your technicians can do that, and sometimes they can't and they have to come out. So, we try to keep up with the service agreements. I think right now our Argon and Optos are pretty new, and it gets looked at once a year. Otherwise, we don't buy that extended warranty. It's very expensive, and we're kind of just taking our chances if something happens. But then, you pay a lot. These are very expensive pieces of equipment, and they're not easy to replace. So at that point, you have to make a decision on how often it's going down and what the next move is.
So what changes, whether at the institutional or industry level, could reduce the likelihood or impact of these failures? And is there room for more standardized contingency planning in ophthalmology?
Yeah, I don't know. I think going to meetings and talking to other colleagues is definitely the way to go. Like, how do you handle it? We learn from each other, but contingency plans are very hard. I mean, if my machine laser equipment is down, I can't really send them to the neighborhood ophthalmologist that's, 3 miles away, because they're using all their equipment as well. Sometimes the company has given us a loaner, and that can happen, but it doesn't happen immediately. That also can take a few days. And if it's really, really important, of course, you can send your patient to the university or a neighboring ophthalmologist. So, I mean, patient care will always come first. We'll always figure out a way.
Sure.
If there's a certain patient that absolutely needs it, because I have colleagues that are close by, or I have colleagues at the university where I just make a phone call and say, look, this really has to happen. So we'll always do what's best for the patient, but it can be inconvenient.
So kind of wrapping things up, for glaucoma specialists or administrators listening, what's one piece of advice you'd offer to prepare better for inevitable technical breakdowns? And what gives you optimism that care continuity can be strengthened going forward?
I think it takes a village. It takes a team to really figure this out. I mean, I don't know everything about the technology. So, we have layers of business manager, and then we have an IT person, that can look ahead and not just predict problems that are going to happen with the current computers are too slow, or the phone may need to be changed, or we should think about this. Things that I would have never thought about because I'm too busy in ophthalmology. So you need to surround yourself with a forward-thinking team. You need to have people that are good at different things, not just being a doctor. And then that's how you can run a business, because they can see that all the technical things, the computers, the phones, the answering service, all that stuff. And HR, it's so important. Doctors necessarily aren't taught to be business people. We aren't taught how to run HR. So you have to surround yourself with the right people that can help you with all those tasks, so you can concentrate on seeing patients and doing what's best for patients.
Yeah, especially in your role being, what was it at the practice? You said you're the managing partner, or what's the title there?
Yeah,
managing. So you
Mm-hmm.
like kind of direct all this traffic and make sure the trains run on time, on top of being,
Right.
a glaucoma specialist handling and caring for your patients. So surrounding yourself with, good people who can, when you delegate something, it's going to get done. And
Exactly.
having that management of people and those communication skills, obviously you're in the role so that you do a very good job. But I think anybody like an administrator or a surgeon who is in a similar role as yours got to have, again, the right infrastructure around them so that they're not like pulled in all these different directions, taking them away from the focus of their patients.
Right. Agree.
Hey, well, thanks a lot for coming on, Dr. Hawkins. It's been amazing. I love it when folks
thank
come
you
on.
so much for inviting me. It's been a pleasure talking to you.
No problem at all. So it was a pleasure having you on, visiting the Q Switch. As always, we'd like to thank Riverside FM and Passionate Media for making this show possible. That's a wrap for this episode of the Q Switch Conversations podcast. Until next time, this is Spence, and I'm out.
Bye-bye.
You're listening to The Q Switch with your host, Spence.